Hi everyone, welcome to PharmaGrid. So, in this session, we are going to learn about clinical toxicology, mainly the drug toxicity and its associated treatment, and we will also discuss regarding the general treatment options or what all are the general management options in cases of poisoning or overdose, as well as specific injections of certain drugs and what all are their antidotes available. So, everything we will discuss in detail in this particular video. So we all might be aware about the term poisoning. Okay, so for every drug or any chemical or anything, there is a particular limit. So if it exceeds the limit, it can lead to poisoning. So this poisoning is an adverse effect from a chemical that has been taken in excessive amounts. The body is able to tolerate and in some cases detoxify a certain dose of a chemical. However, once a critical threshold is exceeded, it will result in toxicity. Poisoning can produce minor local effects which can be treated readily in the outpatient setting, or some cases it may get worsened or can lead to systemic life-threatening effects which may require intensive medical intervention. Poisoning by chemicals include exposure to drugs, industrial chemicals, household products, plants, venomous animals, and agrochemicals. Toxins can enter into your body through different routes. These toxins can be inhaled, insufflated, orally injected, and absorbed dermally. So let's see some of the important definitions related to this chapter. So first one, clinical toxicology. So it is a subspecialty of toxicology dealing with the bedside management of poison patients, including the definitive toxicological diagnosis, assessment of immediate severity and long-term prognosis, and selection of treatments including antidotes. Or else we can say that this clinical toxicology focuses on the effects of substances in patients caused by accidental poisonings or intentional overdoses of medications, drugs of abuse, household products, or various other chemicals. Okay, so it is nothing but it mainly deals with the bedside management of poison patients. Okay, from the term clinical itself, it is understood. And the next term is intoxication. It means toxicity associated with any chemical substance. Poisoning, a clinical toxicity secondary to accidental exposure. Overdose means an intentional exposure with the intent of causing self-injury or death. Then toxidrome. Toxidrome means it is a group of signs, symptoms and laboratory findings that suggest a specific ingestion. So, knowledge of potential drug and chemical hazards allows a clinical toxicologist to participate in the preparedness for and prevention of chemical intoxications. Here we will see about the general approaches to the treatment of the poison patient. Stepwise care approach. First of all, diagnosis. Suspect and identify the poison if possible. No need to wait until the poison got identified. Always try to provide the emergency treatment for the particular patient or the poison patient. Then treatment includes basic principles, antidotes, symptomatic and supportive. Anticipate complications, preserve evidence and prevent sequelae as well as recurrence. And here you can see the first aid for poison exposures. As I have already mentioned, toxins can enter into your body through different routes. So based on that routes, there are certain first aid measures available. So if it is an inhaled poison, immediately get the person to fresh air, avoid breathing fumes, open doors and window. If victim is not breathing, start artificial respiration. Then if poison got entered into the body through the skin. Okay, so if the poison on the skin, remove contaminated clothing and flood skin with water for 10 minutes. Wash gently with soap and water and rinse. Avoid further contamination of victim or first aid providers. Then if poison in the eye, flood the open eye with lukewarm or cool water poured from a glass 2 or 3 inches from the eye. Repeat for 10 to 15 continuous minutes. Remove contact lenses. Then swallowed poison. Unless the patient is unconscious, having convulsions, or cannot swallow, give 2 to 4 ounces of water immediately and then seek further help. So first of all, the emergency treatment of the poison patient. Evaluating and supporting the vital functions, mainly this airway, breathing and circulation, are the mandatory first steps in the initial management of drug injections. After the patient is stabilized, the specific issue of poison management should be addressed. Then in case of poisoning, the basic principle is to treat the patient, not the poison. Poison patients may deteriorate rapidly. Care for all patients who are critically ill or under evaluation for possible toxin exposure or ingestion, particularly when the history is uncertain, should begin in a monitored treatment area where the development of central nervous system depression, hemodynamic instability or seizures can be rapidly recognized and addressed. Airway breathing and circulation are assessed and addressed initially along with any other immediately life-threatening toxic effect. For example, profound increases or decreases in blood pressure, heart rate, respirations, body temperature, or any dangerous dysrhythmias. Acid base and electrolyte disturbances, acetaminophen and salicylate blood levels, and results of other appropriate drug screens can be further assessed as laboratory results are obtained. After administering oxygen, obtaining intravenous access and placing the patient on a cardiac monitor, the poisoned patient with altered mental status should be considered for administration of the coma cocktail. So, coma cocktail is usually administered to poison patient with altered mental status. So the coma cocktail consists of mainly three medications. Okay, intravenous dextrose in order to treat hypoglycemia, which is a possible toxicological cause of altered mental status, and the next medication is naloxone to treat possible opioid or clonidine toxicity, and the next one is thiamine for ethanol-induced Wernicke encephalopathy. So this coma cocktail is mainly administered to poison patients with altered mental status, and this coma cocktail consists of mainly three medications, that is intravenous dextrose, naloxone and thiamine. Now we will see about the different methods, that is general methods that can be used for the removal of poison. Okay, that is nothing but decontamination. So once the patient is stabilized, decontamination can occur, which means removal of poison from the person. After getting quick information about the type of exposure, the decontamination step is adopted as a first aid measure. First aid measures we have already seen in the previous slide. So the clothes soiled with poison is removed and the exposed surface is washed with an adequate amount of clean water. Chemical or poison exposure to eye requires wash with saline, that is irrigating solution, to reach neutral pH. In case of exposure such as toxic gases, the affected person must be brought out to an open ventilated place and if required, artificial respiration be given. Gastrointestinal decontamination with gastric lavage, activated charcoal or all bowel irrigation. Whole bowel irrigation means utilizing a polyethylene glycol electrolyte balanced solution for ingestions. So these are the different methods. Okay, we have already seen the first aid measures that can be used for the removal of poison. So other than this, gastrointestinal decontamination methods mainly includes gastric lavage, activated charcoal and all bowel irrigation. With rare exceptions, gastric lavage, whole bowel irrigation and administration of syrup epic are no longer recommended. Therapy should be administered preferably within 1 hour of ingestion. Induction of MSS is contraindicated in cases of corrosive poisoning, in unconscious patients and in those who have swallowed petroleum products. Mechanical tickling of the throat with fingers, spatula or tongue depressor will induce vomiting. Sometimes syrup ipecac 10 to 20 ml may be used followed by half a glass of water, but it is contraindicated in children aged less than 6 months. So let's first see about gastric lavage. So gastric lavage involves placing a tube through the mouth. Okay, so placing a tube through the mouth, which is known as the orogastric tube, or through the nose known as nasogastric tube, into the stomach. Okay, so through the mouth or through the nose we are inserting a tube into the stomach and washing out of the gastric contents through repetitive instillation and withdrawal of the fluid. So this is how gastric lavage is performed. And this method is considered only if a potentially toxic agent has been ingested within the past hour for most patients. If the patient is comatose or lacks a gag reflex, gastric lavage should be performed only after intubation with a cuffed or well-fitting endotracheal tube. Lavage should be performed with warm, normal saline or tap water. That is, temperature should be between 37 to 38 degrees Celsius. So this lavage is performed until the gastric return is clear. This usually requires 2 to 4 liter or more of the fluid. Relative contraindications for gastric lavage include ingestion of a corrosive or hydrocarbon agent. Then complications of gastric lavage include aspiration pneumonitis, laryngospasm, mechanical injury to the esophagus and stomach, hypothermia and fluid and electrolyte imbalance. Now we will see about single dose activated charcoal. Reduction of toxin absorption can be achieved by administration of activated charcoal. It is a highly purified adsorbent form of carbon that prevents gastrointestinal absorption of a drug by chemically binding, that means adsorbing the drug to the charcoal surface. There are no toxin-related contraindications to its use, but it is generally ineffective for iron, lead, lithium, simple alcohols, and corrosives. It is not indicated for aliphatic hydrocarbons because of the increased risk for emesis and pulmonary aspiration. Activated charcoal is most effective when given within the first few hours after ingestion, ideally within the first hour. The recommended dose of activated charcoal for a child 1 to 12 years old is 25 to 50 gram. For an adolescent or adult, the recommended dose is 25 to 100 gram. So the next gastrointestinal decontamination method is whole bowel irrigation. So here polyethylene glycol electrolyte solutions are used routinely as the whole bowel irrigants prior to colonoscopy and bowel surgery. Here large volumes of these osmotically balanced solutions are administered continuously through a nasogastric or duodenal tube for 4 to 12 hours or more. They quickly cause gastrointestinal evacuation and are continued until the rectal discharge is relatively clear. And this whole bowel irrigation is indicated for certain patients in whom the ingestion occurred several hours prior to hospitalization and the drug still is suspected to be in the gastrointestinal tract, such as drug smugglers who swallow condoms filled with cocaine. In addition, patients who have ingested delayed release or enteric coated drug formulations or have ingested substances such as iron that are not well absorbed by activated charcoal may benefit from whole bowel irrigation. It should not be used in patients with a bowel perforation or obstruction, gastrointestinal hemorrhage, ileus or intractable emesis. Emesis, abdominal cramps and intestinal bloating have been reported with whole bowel irrigation. So far, we have learned about the gastrointestinal decontamination methods, which includes the gastric lavage, use of activated charcoal, and whole bowel irrigation. Now we will see about the elimination enhancement. Elimination of poisonous substances can be enhanced by the use of diuretics such as furosemide, ethacrynic acid, acetazolamide, and of osmotic substances such as urea and mannitol. Forced alkaline diuresis treatment is done in patients of barbiturate intoxication. Other effective measures to eliminate ionizable substances are peritoneal dialysis, hemodialysis, and exchange transfusions. So the first method is hemodialysis. The elimination of some medications or toxins may be enhanced by hemodialysis if certain properties are met, such as low protein binding, small volume of distribution, small molecular weight, and water solubility of the toxin. Okay, so poisoning hemodialysis will be useful only in such cases if these criteria will be met. The criteria are low protein binding, that is the poison substance or the drug have low protein binding, small volume of distribution, and it should be of small molecular weight and has got high water solubility of the toxin. Examples of medications or substances that can be removed with hemodialysis include methanol, ethylene glycol, salicylates, theophylline, phenobarbital, and lithium. The next method is urinary alkalinization, or else we can say that alkaline diuresis. Alkalinization of the urine to achieve a urine pH of 7.5 or greater for poisoning by weak acids such as salicylates or phenobarbital can be achieved by intravenous administration of sodium bicarbonate 1 to 2 milliequivalent per kilogram, which means 1 to 2 millimole per kilogram over a 1 to 2 hour period. So this alkaline diuresis or urinary alkalinization is usually preferred for poisoning by weak acids such as salicylates or phenobarbital, and here we are mainly administering the intravenous sodium bicarbonate in a dose of 1 to 2 milliequivalent per kilogram over a 1 to 2 hour period. Complications of urinary alkalinization include alkalosis, fluid and electrolyte disturbances, and inability to achieve target urinary pH values. So increasing the urine pH with intravenous sodium bicarbonate transforms the drug into an ionized form. So this is the principle behind urinary alkalinization. So increasing the urine pH, what will happen? So we are increasing the urinary pH with the help of sodium bicarbonate. Okay, so this will transform the drug into an ionized form. So when the drug get enter into its ionized form, it cannot be reabsorbed. Okay, so when we have learned about pharmacokinetics, we have already learned that only the unionized form will be absorbed, okay, whereas the ionized form will be excreted. So this is the principle that is applicable to here also, that is the administration of sodium bicarbonate increases the urinary pH that will convert the drug into an ionized form, okay, which will prevent its reabsorption, thereby trapping it in the urine to be excreted by the kidney. That is how the poison will be eliminated from the body. And the next one is the use of multiple dose activated charcoal. So this will enhance the elimination of certain drugs, for example, phenobarbital, digoxin, carbamazepine, alkaloids such as atropine, morphine, reserpine, and theophylline. Activated charcoal is extremely porous and has a high surface area, which creates a gradient across the lumen of the gut. Gradient means there will be a concentration difference. So as a result, medications traverse from areas of high concentration to low concentration, promoting absorbed medication to cross back into the gut to be absorbed by the activated charcoal. In addition, activated charcoal blocks the reabsorption of medications that undergo intrahepatic recirculation, such as phenytoin, by adsorbing the substance to the activated charcoal. Once the drug is adsorbed to the charcoal, it is eliminated with the charcoal in the stool. So here you can see the diagram. How or what is the mechanism of action of multiple dose activated charcoal? So this activated charcoal usually creates a concentration gradient. So here you can see the activated charcoal is given in the green color and the blue one is the drug. So due to this gradient or due to this concentration difference, what will happen? The drug will move from areas of high concentration to low concentration. That is, the drug will move back into the gut and get adsorbed onto the activated charcoal. Okay. Also, in addition to this, the activated charcoal also blocks the reabsorption of medications that undergo enterohepatic recirculation. So ultimately what will happen? All the drugs, all the poison drugs got adsorbed onto the activated charcoal and it will be eliminated in the stool. Okay. So the bowel sounds must be present prior to each activated charcoal dose to prevent obstruction. Charcoal should not be administered in cases of ingestion of caustic substances, metals, or hydrocarbons. In patients who are at risk for aspiration, endotracheal intubation and head of bed elevation should be performed before charcoal administration. Now we will see about antidotes. So these antidotes play an important role in the management of most toxins and are essentially life-saving when used as early as possible in the treatment of toxins with non-antidotes. For example, N-acetylcysteine, which can be used as an antidote for paracetamol poisoning, then naloxone for opioid toxicity or opioid poisoning, then pyridoxine. Pyridoxine, also known as vitamin B6, which can be useful in order to reduce the toxicity associated with isoniazid. Isoniazid is an anti-tubercular drug. Chelating drugs are used in cases of poisoning with heavy metals and occasionally with other drugs. So here you can see certain toxic agents and their antidotes available. So some examples are for warfarin. Warfarin is an oral anticoagulant. The antidote available is vitamin K. For heparin, the antidote available is protamine sulfate. Then for benzodiazepines, the antidote is flumazenil. Then carbon monoxide, antidote is oxygen. So likewise, you can refer this tabular column in order to learn about the toxic agents as well as their specific antidotes. Ongoing supportive measures. Most symptoms, for example, agitation, sedation, coma, cerebral edema, hypertension, arrhythmias, renal failure, and hypoglycemia, are treated with the usual supportive measures. Fluid and electrolyte disturbances are managed with proper laboratory investigations and assessment of intake and output. Then careful monitoring of vital signs such as temperature, pulse, respiration, and blood pressure is mandatory. Metabolic needs get increased by about 10% and then the temperature rises by about 0.8 degrees Celsius. Hyperthermia means increase in the body temperature, is treated with aggressive sedation and physical cooling measures rather than with antipyretics. Then hypothermia means decrease in the body temperature. This hypothermia delays detoxification and excretion of poison due to reduced metabolism and circulatory disturbances. A comatose patient needs careful supervision for clear airway, proper oxygenation, prevention of aspiration of gastric contents by proper positioning, frequent change of position, and care of bladder, bowels, skin, eyes, and buccal mucosa. Then antibiotics for infections are given according to the needs. Drug-induced hypotension and arrhythmias may not respond to the usual drug treatments. For refractory hypotension, dopamine, epinephrine, other vasopressors, an intra-aortic balloon pump or even extracorporeal circulatory support may be needed. Seizures are first treated with benzodiazepines. Phenobarbital or phenytoin may be required. Complications arising commonly in poisoning. Anticipating complications arising due to poisoning and their proper management help in a successful outcome. Prevention of sequelae such as strictures following corrosive poisoning is done by using corticosteroids. Corticosteroids are useful in petroleum product poisoning to treat shock and lung syndrome and to prevent pulmonary fibrosis. Preserving evidence for medico-legal purposes and toxicological studies is the responsibility of the attending physician. Urine, stool, gastric contents, mainly the vomited or aspirated, then blood and food samples and viscera should be preserved. Now we will see about prevention. What are the preventive measures that can be opted? Proper labeling of household products and prescription drugs, then keeping medicines, cosmetics and household products separately, then storing such substances in cabinets that are locked and inaccessible to children, and providing psychiatric consultation to patients who have taken drugs with suicidal intention. Then next measure is use of child resistant containers with safety caps reduces the number of poisoning deaths in children. Limiting the number of over-the-counter analgesics in a single container and eliminating confusing and redundant formulations or fixed dose combinations reduce the severity of poisoning, particularly with acetaminophen, aspirin or ibuprofen. Public education measures to encourage storage of substances in their original containers. For example, not placing insecticides in drinking bottles are also important. So now we will learn about selected pharmaceutical and occupational toxicities. So the first one is acetaminophen or paracetamol. It is an antipyretic analgesic agent that can produce fatal hepatotoxicity in untreated patients through the generation of a toxic metabolite. Acetaminophen is metabolized in the liver primarily to glucuronide or sulfate conjugates, which are excreted into the urine with small amounts of unchanged drug. Approximately 5% of a therapeutic dose is metabolized by the cytochrome P450 mixed function oxygenase system, primarily CYP2E1, to a reactive metabolite N-acetyl parabenzoquinone. In short, it can be denoted as NAPQI. This metabolite normally is conjugated with a glutathione. Glutathione is a sulfhydryl containing compound in the hepatocyte and excreted in the urine as a mercapturate conjugate. Okay, so here you can see this is acetaminophen, and usually this acetaminophen undergo metabolism in the liver mainly by glucuronidation and sulfation, and only about 5% is metabolized by the cytochrome P450 mixed function oxygenase, and the metabolite formed, and as a result a reactive metabolite is formed which is known as NAPQI or N-acetyl parabenzoquinone. So in normal conditions or in therapeutic doses, what will happen? This toxic intermediate or this toxic metabolite reacts with a glutathione. Glutathione is a sulfhydryl containing compound in the hepatocyte, and it will get converted to mercapturic acid, which is non-toxic and thereby excreted through urine. So this is the case of in case of therapeutic doses of paracetamol. So what will happen if we take an excess amount, or in case of toxic dose of paracetamol, what will happen? All the glutathione got depleted. So this toxic intermediate or this toxic metabolite, that is NAPQI, will react with the nucleophilic hepatic cell proteins. Okay, if all the glutathione stores are depleted, what will happen? The reactive metabolite, that means the NAPQI, it reacts with the hepatic cell itself. Okay, it reacts with the hepatocellular sulfhydryl compounds such as those in the cytosol, cell wall and endoplasmic reticulum. So ultimately what will happen? This will result in centrilobular hepatic necrosis. So this is a mechanism by which paracetamol causes hepatotoxicity. Okay, so in an acute overdose situation, sulfate stores are depleted, shifting more drug through the cytochrome system, thereby depleting the available glutathione used to detoxify the reactive metabolite. Okay, so usually this reactive metabolite are detoxified with the help of glutathione. So in overdose, what will happen? So all the sulfate stores got depleted. So more drugs undergo metabolism through this cytochrome system. So more toxic intermediates will be formed and all the glutathione stores will be depleted. So ultimately it will result in centrilobular hepatic necrosis. The reactive metabolite NAPQI reacts with other hepatocellular sulfhydryl compounds such as those in the cytosol, cell wall and endoplasmic reticulum. So altogether it will result in hepatotoxicity. So again, this is the same thing what I have already mentioned. The pathway of acetaminophen metabolism and the basis for hepatotoxicity. So this is acetaminophen and metabolized in the liver mainly through glucuronide conjugation, sulfate conjugation, and some amount is excreted unchanged in urine, and about a small percentage, about 5% through the cytochrome P450 mixed function oxygenase system. So the toxic intermediate formed is NAPQI, N-acetyl parabenzoquinonamine. So in therapeutic doses, this NAPQI reacts with the glutathione. Okay, glutathione in the hepatocytes and forms a non-toxic mercaptopuric acid. Okay, and it got excreted through the urine. And if in acute overdose, what will happen? There will be depletion of glutathione. Okay, so the reactive metabolite will not be detoxified or will not undergo detoxification. That will lead to hepatocellular necrosis. Moving on to the phases of acetaminophen toxicity, there are mainly four phases typically describing acetaminophen toxicity. Phase 1, 0 to 24 hours. The symptoms include loss of appetite, nausea, vomiting, general malaise. Then phase 2, 24 to 72 hours. The signs and symptoms include abdominal pain, increased liver enzymes. Then phase 3, 72 to 96 hours. Liver necrosis, jaundice, encephalopathy, renal failure, death. Phase 4, greater than 4 days to 2 weeks. Complete resolution of symptoms and organ failure. So these all are the four phases of acetaminophen toxicity. And here you can see the clinical presentation of acute acetaminophen poisoning. General, no or mild non-specific symptoms within 6 hours of ingestion. Symptoms mainly include nausea, vomiting and abdominal discomfort within 1 to 12 hours after ingestion. Right upper abdominal quadrant tenderness typically within 1 to 2 days. Then signs. Typically there will be no signs present within the first day. Then jaundice, scleral icterus, bleeding within 3 to 10 days. Then oliguria, occasionally within 2 to 7 days. Then with severe poisoning, hepatic encephalopathy, which includes delirium, depressed reflexes and coma within 5 to 10 days. Okay. Then what are the major laboratory tests? Okay. Toxic serum acetaminophen concentration no earlier than 4 hours after ingestion by comparison with nomogram. Then elevated AST, that is aspartate aminotransferase, and ALT, that is alanine aminotransferase, serum bilirubin and INR, that is international normalized ratio. Then hypoglycemia within 1 to 3 days. Elevated serum creatinine and blood urea nitrogen within 2 to 7 days. Now, the antidote for acetaminophen toxicity, N-acetylcysteine, works as a glutathione precursor and glutathione substitute and assists with sulfation. N-acetylcysteine may also function as an antioxidant to aid in recovery. Okay, as we have already discussed the mechanism, this hepatotoxicity is mainly due to depletion of glutathione. So, this N-acetylcysteine mainly works as a glutathione precursor and glutathione substitute, and it assists with sulfation and also acts as an antioxidant. Then this antidote is most effective when initiated within 8 to 10 hours of ingestion. The selection of this N-acetylcysteine, suppose for a particular patient, this antidote is required or not, and this is selected based on a nomogram which is known as Rumack-Matthew nomogram. So this nomogram is based on the time of ingestion, and the serum acetaminophen level is utilized after an acute ingestion to determine if N-acetylcysteine therapy is needed. So here you can see the nomogram. Nomogram for assessing hepatotoxic risk following acute ingestion of acetaminophen. So here plasma acetaminophen concentration is plotted, and here the hours after acetaminophen ingestion. This nomogram is helpful to predict acetaminophen toxicity when levels can be obtained between 4 and 24 hours post ingestion. So here you can see a nomogram treatment line. The treatment line concentration is 150 microgram per ml at 4 hours. Okay, so here you can see this is the treatment line that is set as 150 microgram per ml at 4 hours. Okay, at 4 hours, which allows a margin of error in laboratory analysis, and time of ingestion should be used to make treatment decisions. So if the plasma concentration plotted on the nomogram falls above the treatment line, so here you can see the treatment line, and if the plotted concentration is above the treatment line, indicates that hepatic damage is possible for that particular patient, and a full course of treatment with acetylcysteine is indicated. So here you can see the lower limit for probable risk group and the lower limit for high risk group. So this is the treatment line. So any concentrations above this treatment line may be indicative of the use of acetylcysteine. Moving on to alcohol poisoning. So methanol and ethylene glycol. Methanol is also known as wood alcohol. Methanol is found in products such as windshield washer fluid and model airplane fuel. Ethylene glycol is most commonly found in radiator antifreeze. In India, the primary reason for methanol poisoning is the consumption of country liquor or methylated spirit. These primary alcohols cause CNS depression. So now we will see the mechanism. Methanol gets converted by alcohol dehydrogenase into formaldehyde as metabolic intermediate, which in turn gets converted to formic acid by aldehyde dehydrogenase. So this is how an alcohol is metabolized. Okay, so methanol is an alcohol. It get converted to an aldehyde. Okay, by alcohol dehydrogenase. Okay, so methanol in the first step by the action of alcohol dehydrogenase, it will get converted to formaldehyde. And this formaldehyde, which in turn gets converted to formic acid by the action of aldehyde dehydrogenase. Okay, so this ethanol will get converted to aldehyde, then aldehyde to acid. So the lethal dose of methanol is approximately 30 to 240 ml or 1 gram per kilogram. Blindness can happen even with the minimum ingestion of 30 ml of methanol. So we have seen the metabolic pathway. This methanol get converted to formaldehyde and formaldehyde get converted to formic acid. So this conversion of formic acid is responsible for severe toxicity, which includes blindness or even death. Retinal damage is primarily due to the formic acid's oxidative stress. So here you can see the pathway again. Methanol by the action of alcohol dehydrogenase get converted to formaldehyde. And this formaldehyde by the action of aldehyde dehydrogenase it get converted to formic acid. This formic acid is responsible for causing retinal injury and permanent blindness. Methanol follows zero order pharmacokinetics, which means it is a dangerous drug. Methanol poisoning is manifested by vomiting, severe epigastric pain, disorientation, hyperventilation, dyspnea, bradycardia, and hypotension. If untreated, methanol ingestion may produce blindness, metabolic acidosis, seizures, and coma. In general, treatment for methanol poisoning includes supportive care, which includes intravenous sodium bicarbonate infusion, fomepizole, ethanol, dialysis, and supplementation of folate. Ethanol is an alternative antidote if fomepizole is not available. Fomepizole inhibits the oxidative pathway by blocking alcohol dehydrogenase. So antidote for methanol poisoning is fomepizole. So here you can see, here is the step where fomepizole acts. Fomepizole inhibits the oxidative pathway. This oxidative pathway by blocking alcohol dehydrogenase. As ethanol has more affinity for alcohol dehydrogenase, it can saturate the enzyme at the concentration of 100 mg per deciliter. Therefore, ethanol can retard the metabolism of methanol into formaldehyde and formic acid. Hence, in the absence of fomepizole, ethanol can also be used for methanol poisoning. It prevents the formation of toxic metabolites and allows the parent alcohol to be excreted by the kidney. Ethanol is usually administered as a 10% solution in water through a nasogastric tube. In the absence of pure ethanol, to make 10% solution, commercial alcoholic preparations such as a whiskey, gin or brandy can be diluted appropriately for this purpose. Ethanol substitution therapy can cause hypoglycemia which needs to be corrected. Hemodialysis is often utilized to remove the toxic acids that are already produced. This treatment needs to continue for a prolonged period and periodic alcohol measurement in blood needs to be monitored. In addition, cofactors are administered to encourage metabolism to non-toxic metabolites. Folate for methanol, thiamine and pyridoxine for ethylene glycol. Okay, so other than this antidotes, certain uh, cofactors are administered in case of alcohol poisoning. That is, in case of methanol, folate is used as a cofactor to encourage the metabolism to non-toxic metabolites, whereas in case of ethylene glycol, the cofactors used are thiamine and pyridoxine. Now we'll see about ethylene glycol. Ethylene glycol is metabolized into toxic products such as glycolic, glycoxylic and oxalic acid. So here you can see the metabolic pathway. Again, this ethylene glycol is an alcohol. By the action of alcohol dehydrogenase, it will get converted to glycoaldehyde, and by the action of aldehyde dehydrogenase, it will get converted to glycolate, then to calcium oxalate crystals, which causes renal failure. Okay, so the toxic products associated with ethylene glycol are glycolic, glycoxylic and oxalic acid. So ethylene glycol ingestion may lead to renal failure, hypercalcemia, metabolic acidosis and heart failure. The treatment of ethylene glycol ingestion should be treated in a similar manner to that of methanol poisoning. That is, the antidote available for alcohol poisoning is fomepizole. So here you can see this is how the fomepizole acts. So we have seen about methanol and ethylene glycol. Now about isopropanol, which is also known as rubbing alcohol or isopropyl alcohol. This secondary alcohol is metabolized to acetone via alcohol dehydrogenase. Acetone cannot be further oxidized to carboxylic acids and therefore acidemia does not occur. Because isopropyl alcohol is not metabolized to a toxic metabolite, no antidote is necessary to treat an isopropyl alcohol ingestion. Isopropanol is non-CNS depressant, approximately twice as intoxicating as ethanol and gastrointestinal irritant. So treatment centers on supportive care. Moving on to carbon monoxide poisoning. It is a colorless, odorless and a tasteless gas. It is a natural byproduct of the combustion of carbonaceous materials, and common sources of this gas include automobiles, poorly vented furnaces, fireplaces, wood burning stoves, kerosene space heaters, house fires, charcoal grills and generators. So now let's see the mechanism by which this carbon monoxide causes poisoning. So we know that this hemoglobin molecule is a combination of protein globin and non-protein portions called heme, and it is responsible for transporting oxygen in the blood. This hemoglobin is composed of 4 subunits, that is 2 alpha subunits and 2 beta subunits, each of which contains a heme group and globin chain. The heme group contains an iron atom in its ferrous form, that is Fe2 plus form at its core, that binds one oxygen molecule, allowing one hemoglobin tetramer to bind 4 oxygen molecules. That is, in normal case, that oxygen has got high binding affinity to hemoglobin. But in case of carbon monoxide, what will happen? Following inhalation, carbon monoxide rapidly binds to hemoglobin to produce carboxyhemoglobin. The binding affinity of carbon monoxide to hemoglobin is 230 to 270 times greater than that of oxygen. And there is one more problem also. This bound carbon monoxide increases hemoglobin affinity for oxygen at the other oxygen binding sites. Normally, this oxygen is transported to tissues with the help of hemoglobin. So, if this carbon monoxide has bound to this hemoglobin, there will be formation of carboxyhemoglobin. This carboxyhemoglobin has got high binding affinity for oxygen. So, this high binding affinity prevents oxygen unloading to other tissues. That is, oxygen will not be delivered to the tissues. Okay, thereby reducing the oxygen delivery. The presence of this highly oxygenated blood may produce cherry red skin. So this cherry red skin is a characteristic feature of carbon monoxide poisoning. And in this graph, you can see the effect of carbon monoxide on the oxygen affinity of hemoglobin. So thus, in the presence of carbon monoxide, a person can experience severe tissue hypoxia. The carbon monoxide toxicity can also occur following inhalation or ingestion of methylene chloride found in paint strippers. Once absorbed, methylene chloride is metabolized to carbon monoxide through the hepatic cytochrome P450 pathway. The symptoms of carbon monoxide intoxication are consistent with hypoxia, including headache, dyspnea, lethargy, confusion, and drowsiness. Higher exposure levels can lead to seizures, coma, and death. The management of a carbon monoxide poison patient includes prompt removal from the source of carbon monoxide and institution of 100% oxygen by a non-rebreathing face mask or an endotracheal tube. In patients with severe intoxication, oxygenation in a hyperbaric chamber is recommended. Now let's see about cyanide poisoning. Cyanide is one of the toxic products of combustion produced during house fires. Its principal toxicity occurs as a result of the inactivation of the enzyme cytochrome oxidase, that is cytochrome A3, leading to the inhibition of cellular respiration. Therefore, even in the presence of oxygen, tissues with a high oxygen demand such as the brain and heart are adversely affected. So the mechanism by which cyanide causes toxicity is mainly through the inactivation of the enzyme cytochrome oxidase, leading to the inhibition of cellular respiration. Death can occur quickly due to arrest of oxidative phosphorylation and production of adenosine triphosphate. The antidote for cyanide poisoning is hydroxycobalamin, that is vitamin B12A. It is administered intravenously to bind the cyanide and produce cyanocobalamin, that is vitamin B12, without the adverse effects of hypotension or methemoglobin production seen with older antidotes. So regarding this cyanide poisoning, there is an antidote kit was available previously. The older cyanide antidote kit consists of Sodium nitrate. Okay, sodium nitrate means the sodium nitrate reacts with the cyanide to form cyanomethimoglobin. And one more ingredient is there in the cyanide kit, cyanide antidote kit, which is sodium thiosulfate. The purpose of sodium thiosulfate is to accelerate the production of thiocyanate, which is much less toxic than cyanide and is quickly excreted in urine. So regarding the cyanide poisoning, the antidote available is hydroxycobalamin. The cyanide reacts with this hydroxycobalamin to form cyanocobalamin. And also older cyanide antidote kit is also available, which consists of sodium nitrate and sodium thiosulfate. So moving on to the iron toxicity. The incidence of pediatric iron toxicity has greatly diminished during the past 2 decades due to education and changes in packaging and labeling of iron products. Iron is radiopaque and may show up on an abdominal radiograph if the product contains a sufficient concentration of elemental iron. So this iron toxicity or iron poisoning is based on the amount of elemental iron ingested. Toxic effects can be expected with ingestions as little as 20 mg per kilogram of elemental iron, and doses of 60 mg per kilogram may be lethal. Each iron salt contains a different concentration of elemental iron. So there are different iron salts are available. That is sulfate salt, which consists of about 20% elemental iron. Then fumarate salt, 33% elemental iron, and gluconate salt, about 12% elemental iron. So a serum iron level should be obtained since levels between 500 and 1000 microgram per deciliter have been associated with the shock, and levels higher than 1000 microgram per deciliter with death. Patients with iron toxicity usually present with nausea, vomiting and abdominal pain. Depending on the amount of elemental iron ingested, the patient may experience a latent period or may progress quickly to hypovolemia, metabolic acidosis, hypotension and coagulopathy. Ultimately, hepatic failure and multi-system failure, coma and death may occur. Deferoxamine, an iron-specific chelator, binds free iron, creating ferrioxamine, which is excreted in the urine. So the antidote available for iron poisoning is deferoxamine, which is an iron-specific chelator. It's a chelating agent. It binds the free iron and thereby creating ferrioxamine, which is excreted through the urine. Hypotension may occur if rapid intravenous boluses of deferoxamine are administered instead of a continuous infusion. Now we'll see about lead poisoning. So lead is ubiquitous in the environment with sources of exposure including old paint, drinking water, industrial pollution, food and contaminated dust. Most chronic exposure to lead occurs with inorganic lead salts such as those in paint used in housing constructed prior to 1978. Adults absorb about 10% of ingested lead, whereas children absorb about 40%. Inorganic forms of lead are initially distributed to the soft tissues and more slowly redistribute to bone, teeth and hair. So one of the most important problem associated with the lead is that it will affect the bone, teeth and hair. That is, lead impairs bone formation and causes increased calcium deposition in long bones visible on X-ray. Lead is a heavy metal. Ingested lead is radio-opaque and may appear on an abdominal radiograph if present in the gastrointestinal tract. Lead has an apparent blood half-life of about 1 to 2 months, whereas its half-life in the bone is 20 to 30 years. Early symptoms of lead toxicity can include discomfort and constipation and occasionally diarrhea, whereas higher exposures can produce painful intestinal spasms. CNS effects from lead include headaches, confusion, clumsiness, insomnia, fatigue, and impaired concentration. As the disease progresses, clonic convulsions and coma can occur. Death is rare given the ability to treat lead intoxication with chelation therapy. Blood levels of 5 to 20 microgram per deciliter in children have been shown to lower IQ in the absence of other symptoms. Finally, lead can cause hypochromic microcytic anemia as a result of a shortened erythrocyte lifespan and disruption of heme synthesis. So here in this slide, you can see the effect of lead on children and adults. So here again, what all are the symptoms or what all are the problems associated with the lead in children and the problems associated with the lead in adults. And here you can see the lead concentration in the blood. And based on the concentration, what all effects lead can cause in both children as well as adults. Moving on to the treatment of lead toxicity. Multiple chelators can be utilized in the treatment of lead toxicity. When levels are greater than 45 microgram per deciliter but less than 70 microgram per deciliter in children, Succimer, which is an oral chelator, is the treatment of choice. Succimer is also known as dimercaptosuccinic acid. With lead levels greater than 70 microgram per deciliter, or if encephalopathy is present, dual parenteral therapy is required with dimercaprol given intramuscularly and calcium disodium edetate given intravenously. Okay, so these all are the treatment options. So if the lead level is in between 45 to 70 microgram per deciliter in children, Succimer, which is an oral chelator, is the treatment of choice. And if the lead levels is greater than 70 microgram per deciliter, or if encephalopathy is present, dual parenteral therapy is required, which includes dimercaprol given through the intramuscular route and calcium disodium edetate given through the intravenous route. Dimercaprol is suspended in peanut oil and should not be given to those with a peanut allergy. The next one is organophosphate and carbamate insecticides, mainly the organophosphate poisoning. So you might have learned about organophosphates in the cholinergic nervous system chapter. So these insecticides exert their toxicity through inhibition of acetylcholine esterase enzyme. So by inhibiting this acetylcholine esterase enzyme, what will happen? This will lead to subsequent accumulation of excess acetylcholine, which will produce muscarinic as well as nicotinic effects. Nicotinic effects mainly include mydriasis, fasciculations, muscle weakness, tachycardia, hypertension, whereas muscarinic effects include diarrhea, urination, meiosis, bradycardia, bronchuria, emesis, lacrimation, salivation, etc. The carbamates reversibly bind to acetylcholinesterase, whereas organophosphates undergo an aging process to ultimately irreversibly inactivate the enzyme. So these organophosphates irreversibly inactivate this acetylcholinesterase enzyme. Organophosphate nerve agents, examples include sarin, soman and tabun, have the same mechanism of action, but the aging process is much more rapid compared to insecticides. Now moving on to the treatment. So the treatment options mainly include atropine as well as oximes. Atropine is a muscarinic receptor antagonist and pralidoxime. It is an oxime to reactivate cholinesterase, should be administered intravenously or intramuscularly to treat the muscarinic and nicotinic effects respectively. So we have finished some of the major poisonings and what all are the treatment options and what all are their manifestations. So here you can see the respective poisons and their corresponding antidotes and their dose available. So carbon monoxide we have already learned, the antidote is pure oxygen. Then cyanide. Cyanide we can use hydroxycobalamin as well as in older. Previously a cyanide kit were used. Then nitrate and nitrates. If methanoglobinemia is there, treat with methylene blue. Then organophosphates. Organophosphates we can use atropine as well as oximes. Then anticholinergics. Injection physostigmine is usually used. Then regarding this opioid toxicity. So opioid toxicity, what are the symptoms? You can refer to the opioid chapter in the narcotics chapter. So what are the toxicity, how it can be managed. So in narcotics, the antidote available is naloxone. Mainly we are using is naloxone, which is an opioid antagonist. Then for alcohol poisoning, we are mainly using fomepizole or ethanol. Then methemoglobinemia, antidote used is methylene blue. Then phenothiazine is an antipsychotic. Then its toxicity can be treated with the use of diphenhydramine. Then iron antidote is desferoxamine, which is an iron chelator. Then for paracetamol, obviously it's N-acetylcysteine. Then regarding benzodiazepines, the antidote available is flumazenil. Now about arsenic, as an antidote we can use dimercaprol. Another name for dimercaprol is British anti-levisate, or succimer also can be used, also known as dimercaptosuccinic acid. Then about lead, it is also a heavy metal. Succimer or dipencilamine orally in case blood lead levels are higher than 45 microgram per deciliter, or parenteral edetate. Edetate in the sense calcium disodium edetate. Then in case of lead encephalopathy, parenteral dimercaprol is a drug of choice. Then in case of isoniazid, we know this isoniazid is an anti-tubercular drug. So in case of isoniazid toxicity, diazepam can be used for seizure control. Then pyridoxine. Pyridoxine is vitamin B6 in a dose equivalent to the suspected maximum amount of isoniazid ingested. So this isoniazid, in case of isoniazid toxicity, the pyridoxine helps to reverse the isoniazid induced seizures. It is given in gram doses equivalent to the amount of isoniazid ingested. Now about digitalis, digoxin, which is a cardiac glycoside mainly used for the treatment of congestive heart failure. So in case of digoxin toxicity, the antidote available is digoxin immune fab or digibind. Now coming to the anticoagulants, heparin. Heparin, which is an parenteral anticoagulant. So in case of heparin toxicity, antidote available is protamine sulfate. Okay, protamine sulfate given through the intravenous route. Then in case of warfarin, warfarin is an oral anticoagulant. In case of warfarin toxicity, so the major risk or the major problem associated with this anticoagulant toxicity is bleeding. So in case of warfarin toxicity, either we can use transfusions of packed red blood cells, then fresh frozen plasma, and if prothrombin time is elevated, IV or oral vitamin K1 can also be used. So other than this, in case of beta blockers toxicity or poisoning or overdose of beta blockers, we can treat it with the help of general measures such as GA decontamination. So along with this, we can use glucagon. Okay, glucagon can be used. Also in case of calcium channel blockers such as verapamil, diltiazem and other dihydropyridines. So in case of poisoning associated with this calcium channel blockers also, we can use GA decontamination, then calcium chloride, glucagon. All these measures can be used. Okay, so and also in case of toxicity associated with the magnesium. Okay, magnesium. So here the treatment option is 10% calcium chloride. Okay, so in case of magnesium toxicity, calcium chloride is the treatment option. In severe cases, hemodialysis may be required. Then in case of potassium toxicity, okay, so potassium, higher levels of potassium is very dangerous. So in case of potassium toxicity, the treatment options are calcium. That is, administer calcium chloride 10%, 10 to 20 ml to antagonize the cardiac effects of hyperkalemia. And the next treatment option is sodium bicarbonate. Okay, sodium bicarbonate. This 1 to 2 milliequivalent per kilogram through the intravenous route increases the serum pH and causes an intracellular shift of potassium. Then the third treatment option is glucose and insulin. Okay, glucose and insulin can also be given as a treatment option for hyperkalemia or toxicity associated with the potassium. Then the fourth option or next treatment option is cation exchange resins. So what these resins will do? These resins will bind potassium in exchange for another cation. For example, sodium polystyrene sulfonate. Different brands are available. Then hemodialysis. Hemodialysis is reserved for life-threatening hyperkalemia that does not respond to the uh, above above measures. Okay, so we have completed the major poisoning and what are the treatment options and manifestations. So I hope you all have liked this video. Thank you everyone for watching this video. Have a great day.